treatment-resistant epilepsy to choose from. This is a very brief nutshell of the last 10 years data that we've had at NIMHANS, and you can see that temporal remains 80% of what we look at, and about 20% being the extratemporal. So we'll start with temporal lobe epilepsy. These are the most frequently encountered specimens, and most commonly we see hippocampal sclerosis. So we will start with that. Now the surgical specimens that we receive from the surgeon includes three things. You have the temporal cortex, the amygdala, and the hippocampus. And basically our job is very simple. We look at all these three, and I'll take you through what pathology we look at in each of these three samples. We need to tell the surgeon whether there is hippocampal sclerosis, yes or no, and if there is any other pathology in the amygdala and the temporal cortex that is received. Now, step one. This is a normal hippocampus for you. The most important step before we even look at the hippocampus under a microscope is the grossing step. And this is where basically your inputs are required, in the sense that we need an intact hippocampus to be given to us, and we are going to be bread loafing it like this in coronal slices. If we don't do that, none of the pathology can be evaluated. So remember, please give us an intact specimen and don't even dare look at it or touch it with your QSUP. Right? So if and when we get an intact hippocampus, we are just going to look at two changes. One is the degree of neuronal loss, and second is whether there is gliosis or not. And we have our fancy stains to do that. The brown color you're looking at here is a stain which is called a Nguyen stain, which picks up neurons. So wherever you're looking at brown is a neuronal component. On your left is normal for you to compare. I don't think this works. So this V-shaped structure that you're looking at here is the dentate gyrus, and this interlocking C-shaped structure is the Ammon's horn. Basically, we need to look at the extent of neuronal loss, which involves only the Ammon's horn, and by definition, the subiculum and the parahippocampal gyrus are spared. So earlier we had a Weiler grading system. Now what we have is the ILA classification put out in 2013, which everybody follows world over. It is very, very simple to apply, and in fact surgeons can take over reporting. I often hear Dr. Bhaskar telling me that under the operating microscope he can see the dentate, right? And I'm sure he can also see the extent of neuronal loss. But when it comes to us, we are going to divide it into three grades. Grade 0, remember, is extremely rare. It means that there is no neuronal loss. We have type 1, type 2, and type 3. I will show you pictures to make sure you keep awake. So what you're looking at doesn't work. Out here, the first one is a grade 0, which means that there is no neuronal loss in any of the subfields. The classical hippocampal sclerosis, also called type 1, means that except for CA2, all of the other sectors, the CA4, CA3, and CA1, will show neuronal loss. The type 2 will show neuronal loss in CA1 alone. The type 3 will show neuronal loss in CA4 alone. It's that simple. Now you need to remember that the most frequent, almost 90% of the time, we see only the type 1. The type 2 and the type 3, which is isolated CA1 and CA4, is extremely rare. And these are also termed as atypical hippocampal sclerosis. So that's our own data. Most of the time we see a HS type 1. So what about... this is quiz time for you. Which one would you like to see? Would you like to see this or what you're looking at on your right? Remember, you have to you want a hippocampus looking like this. You have to tell me about dentate gyrus, Ammon's horn, etc. So if you have an intact specimen, you're going to be able to do that. In this, you will find us searching for the hippocampus, which is just one tiny bit which we've put within brackets. And this is a specimen which we cannot report for you. Okay, so a good report is essentially in your hands. Now, you would come across a lot of terminologies used. Some people saying Ammon's horn sclerosis, some people saying hippocampal sclerosis, some people saying mesial temporal sclerosis. Technically speaking, you should use Ammon's horn sclerosis because, like I demonstrated, the neuronal loss is seen only in the Ammon's horn. The dentate gyrus will not show, the subiculum will not show, the parahippocampal gyrus will not show. The Ammon's horn and hippocampal sclerosis are kind of synonymous. You have to restrict usage of the term mesial temporal sclerosis only when, in addition to changes in the hippocampus, you see changes in two other structures, either the amygdala or the temporal, the medial temporal. Otherwise, you don't use the term MTS in a pathology report. So, a couple of questions that comes up. Why is hippocampus so vulnerable to seizures? We know that it displays a very low threshold for seizure induction. Seizure initiation at any site tends to spread rapidly because you know that there is a Papa circuit which goes out of hippocampus, comes back to hippocampus, and the entire hippocampus is beautifully wired such that you have excitatory input through and through. And that, people believe, is why it is exquisitely vulnerable to seizure activity. But the second question that you may ask is, why the selectivity of neuronal loss that we were just talking about? And most of this is attributed to the amount of calcium buffering property that you have, and you find that calcium buffering property varies across the different subfields. Dentate gyrus has the highest calcium buffering, and the CA2 has the highest calcium buffering property, and therefore it does not show neuronal loss. It is not susceptible to. So that's one of the reasons that it is believed that there is a selectivity. Another question that you may ask is, what difference does it make, whether it's hippocampal sclerosis grade 0, 1, 2, or 3? Now, essentially, it does have some prognostic value because a classical hippocampal sclerosis has the best outcome. The atypical ones, which I told you, the hippocampal sclerosis type 2 and 3, are the ones with a poorer prognosis. It is also believed now that the outcome of memory and learning performance, if you look at, varies whether you have a type 1 or a type 3. In type 1, interestingly, memory loss is very common, and type 3, although it has a poor prognosis, doesn't have that much of a memory deficit. Now, there are other reasons why the pyramidal neurons are susceptible to seizure activity. One is the most frequently oft-quoted reason is that there are intrinsic neuronal properties probably which make it susceptible. So there are channelopathies, there are receptors, there is glutamate, there is excitotoxicity, all of the things that have been proposed. In addition, nowadays people believe that it's not just the property of the neuron, but a few other things like impaired energy supply, which means back to mitochondrial, which has been implicated in so many different things. People think that the same thing is probably attributable even to the hippocampus. So people have actually found that there are hypermetabolic neurons within the hippocampus, and where there is a deficiency of the mitochondria, it is probably susceptible to neuronal loss. Of course, most of you here are surgeons, so there is also a This is actually a fancy stain which has looked at the number of blood vessels in hippocampus. What you're looking at on top is supposed to be a normal hippocampus, vis-a-vis what you're looking at below, where you see the arrows, you can see that most of those vessels have become really thin. So people believe that there is a regression of the vessels, which is what contributes to hypoperfusion and a sclerotic hippocampus. But all said and done, what we still don't know is whether the hippocampal sclerosis is the cause or effect of seizures. So people have tried to look beyond neuronal loss, because you're looking at loss of neurons and you're saying that seizure activity is coming from hippocampus. So are there any changes? The most frequent changes we look at is gliosis. In addition to that, although the dentate gyrus doesn't show neuronal loss, there are a large number of changes that have been recorded, and the mossy fiber sprouting. So what you're looking at here is a normal hippocampus, that's a GFAP stain, which tells you the amount of glial distribution that you see. Vis-a-vis, this is a sclerotic hippocampus. All that brown tells you there is intense gliosis. So these are the two changes that I've already alluded to, neuronal loss and gliosis. Now back to the dentate gyrus we were talking about. We said there's no neuronal loss. Interestingly, you may find increase in the number of neurons within the dentate gyrus. And it may be to such an extent that you can even have a duplication. So all of these are called dentate granule cell pathology or dysplasias. And people believe that this may be the reason why seizure activity is initiated there. A lot of inputs now on neurogenesis being looked at in the hippocampus. is all in the dentate gyrus. Now, the mossy fiber kindling phenomenon is something that reorganizes the entire hippocampus because you have Amundsen neurons lost, so there has to be new connections that are formed, and this reorganization is another reason why you may be seeing seizure activity. So there is a stain by which we can look at this. So normally you will find that there is a lot, this is the hilum of the dentate gyrus, where you'll see most of the synaptic activity. When you look at hippocampal sclerosis, you'll find extra synapses above the dentate gyrus, and that's called mossy fiber sprouting. So are changes limited only to the hippocampus? The answer is yes and no. Most of the time it is, but you can also find changes in the amygdala. Now, I must confess that although people talk about neuronal loss in the amygdala, they talk about gliosis, and sometimes they even find glioneuronal hamartias, amygdala is the one that's most difficult for a pathologist to interpret, because you're taking out a tiny bit of tissue from the amygdala. Nuclear areas are all dependent on anatomy landmarks. So it's like being in Bangalore trying to negotiate traffic without a GPS. Okay. Neuronal loss, again, very difficult because there's no normal neuronal counts that we have to compare. So most of us say gliosis just because we want something to say. Okay, keep that in mind. Entorhinal cortex is the other recent interest, and people believe seizure activity is coming from entorhinal. That is supposed to have a gatekeeper function, and the rest of all of what I've told you so far is just the sequence of long-standing seizure activity. So we still don't know, but that's a hypothesis. Common is the malformations of cortical development. Now, this terminology was introduced way back in 1996, and there have been a lot of classifications, and Barkovich himself has reclassified his own classification multiple times, and the one we use right now is what is put out in 2012. It's a nice classification. Basically, it is dependent on all of the steps that happens with normal neuronal migration. Okay, so any arrest is what causes a malformation of cortical development, and based on which step is affected, we have 4 types which are called group 1, group 2, group 3, group 4. Group 1 is any abnormal cell proliferation of apoptosis, which can cause atrophy, or it can cause increase in size, which can be focal, it can be non-neoplastic or neoplastic. The only ones most often that you would operate on would be the focal cortical dysplasias or the hamartomas. So this is just an example of periventricular nodular heterotopias. You also have subcortical nodular heterotopias and the band heterotopia, depending on which stage is affected. These are some things that you will not give a pathologist material. So I've just given you pictures for you to see what happens when there is a full thickness neuronal migration. This is under migration, this is over migration, which produce different types of lissencephaly. Group 3 is an abnormal post-migrational development, which includes the polymicrogyria and the schizencephaly, and one type of focal cortical dysplasia, which is a dyslamination, comes into this, which does not have balloon cells. Group 4 is not otherwise classified, most often due to peroxisomal, mitochondrial, and all of the inborn errors of metabolism. This is our own scorecard. Most of the time we see focal cortical dysplasias, and the classification started in 1971. You people still use the term Taylor type cells, but now what we use is the ILAE, which has come in 2011 for classifying focal cortical dysplasias, and they are threatening to give us an update in 2018, which is still not come in print. Now, this new classification did 2 things. It gave us a better definition of what is dyslamination, but it also added a 3rd category, which is called FCD3, which includes FCD type 1, which is associated with other epileptogenic lesions. So that's an FCD plus. Now, the premise is when it is associated with other epileptogenic lesions, they're probably completely different pathogenetically, but then jury is still out on this debate. So this is basically the classification. There's FCD type 1, there's FCD type 2 and 3. Type 1 is dyslamination. Type 2 is, in addition to dyslamination, you have dysmorphic neurons and balloon cells. And type 3 is what I was just telling you, where you have FCD1 plus. So I'll just illustrate. Of course, most often we have the FCD type 2B, which is what you pick up on MRI 2. Our FCD type 1 is extremely rare, and that is world over, it's the same kind of a pattern. So just for you to keep in mind, this is normal lamina architecture where you have 6-layered architecture, alternating granule pyramidal, and this was what gets disrupted in the FCD type 1. You call it an FCD type 1A when this radial dyslamination is there. A horizontal, where there's a missing layer, is the tangential, and the 1C is both. Now, it is believed that 1C was just put in there because if you have radial, if you have tangential, there's a possibility that you can have a 1C, but nobody till now has reported a 1C. Those are again MR negative, and you have to depend on a pathologist to give you the diagnosis. FCD type 2 is what you pick up on MRI, and the widening of the gyrus and your transmantle sign basically corresponds to the presence of these dysmorphic neurons and your famous balloon cells. Interestingly, if you take out balloon cells from tissue, they are intrinsically, they don't spike. There's no electrical activity. Still, this is what we use to make a diagnosis of FCD type 2B. Now, although I said that it's easy to use, remember that there are several problems, and the biggest problem remains with FCD type 1. It is not